The first patient is a 64 years old male. On December 2015, he had an episode of acute pancreatitis with the development of a walled-off pancreatic necrosis. 2 attempts of percutaneous drainage failed. Current problem: abdominal pain and early satiety at every meal.
CT scan shows a well-defined heterogeneous pancreatic peripancreatic collection involving the neck, body, and tail, 13 centimeter in diameter, abutting and compressing the stomach.
Scheduled procedure: EUS guided drainage of WOPN using a lumen opposing self-expandable metal stent mounted on a lateral cautery, enhanced delivery system, hot axios. Learning objectives: how to perform EUS guided drainage using the hot axios, when to use lumen opposing self-expandable metal stents versus plastic stent for pancreatic fluid collections. Let's go to the endoscopic room.
Are we live?
Hey guys, hi.
Good afternoon. I'm really excited and honored. I'm here with fantastic professors around me. Professor Giovannini, Professor Marco Bruno, Professor Alberto Larghi, and Professor Wanseun also. This is an outstanding crowd for a very nice case. I would like first to focus on the EUS image of this fluid collection. So it's, as you can see, it's the mirror image of the CT image. But I want you to notice in the bottom, those debris. And that is already sending us 2 messages. The first message is, this is probably a more complex fluid collection than the CT has shown us. The second message that we have, it's a refractory fluid collection that has failed percutaneous drainage. So obviously the percutaneous drainage was done somewhere else, okay, because I think most people will agree the gold standard in 2016 management of pancreatic fluid collection, and of course Mark Giovannini in his lecture during EUS insisted, is using endoscopy, basically EUS guidance. So this was not done here. The patient finally came to the right place, to the epicenter of endoscopy, and now is going to receive the best treatment. So the big question is, how do we manage a refractory complex fluid collection? In my mind, and I have a lot of experts around me here that can discuss, there's no doubt that we should go metal. Why? Because metal is bigger, metal is going to provide us better drainage, and if we need to go inside the fluid collection to do a debridement, you really want to have metal. I think what do you think, Mark? Do you agree with this?
Not always. You know, I'm not convinced yet.
No, in this case.
I'm sure that there are indications for it, but so far we have managed patients with plastic stents very well. But I agree with you, there is an opportunity that using a bigger lumen of the stent compared to the 2 or 3 plastic stents that you normally place will already facilitate better resolution of this collection without doing a debridement or necrosectomy, which is also a good thing.
So I'm gonna use, because there's a big chance in the future in this refractory collection to have to go to do debridement, to have to go and place an ileocystic drain. I'm gonna go and place the hot axios, and so 50 millimeters. So this is a device that actually, it's a one-step device that is mounted on the delivery system that works with a system of 1, 2, 3, 4. So first of all, you will notice that there is no X-ray backup. This is not a practice that I want to advise, to be done unless you're surrounded by 4 experts around you, and you have
with their hands on the back, huh?
Exactly.
No, you're in charge.
and you have a nice fluid collection that has a very easy access by EUS. In this case, I'm actually comfortable accessing directly the collection with the device. There are cases whenever the angle is difficult, and I remember a case that I did in Marseille where the angle was very difficult, absolutely the need to use a EUS needle with a guide wire placed first. In this case, I think we have a pretty nice shot to get into the fluid collection just using straight up access.
And so what do you take into consideration with regard to the distance between the collection and the stomach
Correct.
wall? Or
Correct. I think here it's also very well apposed. We can measure
Yeah.
actually the apposition of the fluid collection with the stomach wall.
Do you use Doppler
Doppler is very important before anything. I was going to use Doppler before even doing anything because you want to avoid those big vessels. So what you want to do here, you want to basically get the needle out very gently of the delivery system, and you want to really see it. Here it is. So you know now where you don't want to go. Can I have Doppler, please? So you see, you really want to be away from that little vessel over there. Okay, you want to be around there. Okay? So now that I have my angle, we're going to stop the Doppler because, you know, I think we know exactly where to go. And what we need to do now is we have to use the pure cut that you start and then get into the collection. Now that I'm into the collection, you remove the cable that gives you the hot access. You do a little movement inside to make sure that the system is into the fluid collection. You lock the device. This is the second step. You open the area of the handle, which is going to actually deploy the lumina-posing metal stents. And you remain locked because you don't want the stent to slide in. You unlock what controls the stent to be deployed, and then you deploy the very first flange. So you see in this case, actually, the flange is very nicely lined up, the first flange, into the fluid collection. I'm very comfortable unlocking it and pulling just a little bit here, you see? And I want to see it tenting, because that means that at this stage, if I lock it right there and I deploy it, I'm going to be in the stomach. Very important movement now to lock it again so it doesn't slide in and unlock the part that actually will liberate the stents. I'm going to put a little bit of tension on the area here, make sure that it doesn't slide in, and I'm going to liberate the stents using EUS, and I'm going to push it out here. You can see I'm in the stomach, and we can shift to endoscopy here, vision, and the stent is deployed into the cavity. So most people will recommend dilating, and I like to dilate for two reasons. Number one, it allows you don't let, so Alberto doesn't dilate. This is interesting, we're going to take a vote.
I used to dilate. Right now,
Okay.
I just leave it.
So,
Is that migration because of dilation?
so Alberto doesn't dilate,
I
okay?
used to dilate.
Mark, what do? Do you dilate?
I use mainly not the Axios, but the Spaxus stent, which is quite the same system. But I prefer to dilate. Yes.
Okay.
Depends the content of the cyst. If the content is very thick, I prefer to dilate. Yes.
So this is interesting because in the trial, we will actually ask to dilate after deployment into a sort of system.
Me, I used to be very aggressive with dilating.
Yeah.
Then I think.
Can I have a
that
specimen
just
holder?
leave it there, sit
I want to
down
get
for
a
one
trap.
day,
A trap.
Unless you need.
I want to get culture.
Alberto,
Can I have a
Speak
trap?
close
Very
to the
important,
microphone.
now that we have all this fluid that seem to be infected, to actually get a trap, because I want to send this for microbiology. So we can speciate and make a better job with our antibiotherapy.
May I ask you a question? You don't use the endoscopic view to deploy
At
the
the
last
very
part.
end. At the very end.
Mark, we
You
can.
don't see the black marker on the no.
I don't.
You do everything with the US.
So you pull
this
back.
is- You know, how it's called this
Yeah.
technique is intra-channel stent release technique. So we are actually sending a paper
Alberto.
with the group in Milan.
Speak close to the microphone,
So
please.
we are actually sending a paper describing in the video GI section describing the intra-channel stent release technique that is basically US fluoroless US technique where you release the stent without fluoroscopy and without endoscopy, not only for pancreatic fluid collection but also for the gallbladder and for the bile duct. And this is a work done by our group and the group in Milan.
Yeah, that would be a very interesting paper. So I want to show you the specimen. If the camera can zoom on the specimen we're going to take here. This is clearly infected. I mean, this shows two things. Number one, you need something to drain. Big diameter here is going to help. Number two, this demonstrates that percutaneous drainage should not be thought as a first step for pancreatic fluid collection in 2016.
Definitively no. But I think this patient has probably a rupture of the pancreatic duct.
Yes.
Because if the patient relapses after the pectoral use, it's probably because the duct is...
Can you use the microphone?
They might have placed a very small catheter because maybe it's done in a,
We are not able to understand, Alberto and Mark.
So I think the reason maybe because it relapsed is because it was treated outside and maybe they placed a very small percutaneous drainage. In this case, we are going to make Michelle happy and we're going to go ahead and we're going to dilate the tract.
Oh my God, I'm so happy. Can I have a
You want a gastroscope?
I think it's
50 millimeter
Would you
CRE.
please
it's a good
speak in the
indication
phone?
to delay
15 millimeter.
because the
15.
risk
CRE.
is to have impaction of
Balloon
the
dilation.
necrosis when the
Sorry.
fluid
Michael,
Michel.
Michel.
I have two questions.
Yes. I think there's two questions.
Necrosis. And this infection of necrosis
We
can
can't
become
understand Dr.
complication.
Giovannini. He has to use a microphone. We
All right.
hear nothing.
What Mark is saying is that he thinks that dilation in this case is kind of obligatory because you facilitate the extraction of the solid material, which could obstruct the spontaneous drainage of the cyst through the still narrowed lumen.